everyone. We will get started. As always, my name is Emily Weiler. I'm the director of the Montana Public Health Training Center. I am here with Kat Hepburn. She is also with our training center. She's our new training coordinator.
Hi.
And we are very excited today to have another program planning and evaluation training with the marvelous Kimber McKay. And I will be here, me and Kat will be here the whole time. And so we'll be managing the chat box and that kind of thing. So if you have any comments, we'll make sure that they don't get missed. If you have technical issues, give us a holler. If at any point you get booted or your internet struggles, no worries. Click that Zoom link again. We'll let you back in from the waiting room. No issue there. Like I said, we'll be lingering, so just let me know if you need anything. And I will stop sharing here and I will turn it over to Kimber. Take it away.
Okay, sounds good. I'm just gonna share my screen here and show you guys. There we go. So I just wanted to begin by, Emily, can you see the agenda here?
Yes.
Okay, super. So I just wanted to review the agenda for today. And actually, before I do that, I'll just put up this. Can you all see the intros in the chat slide? This is the first slide of my presentation. So if you all could just put in the chat.
We only see your agenda still.
Oh, weird. Okay. So if you would just, everybody who has just logged in or is now joined, if you could just put in the chat, what's your name? Where are you from and where do you work now? What are your main duties at work? And a little bit about if you work with a team or like who are the coworkers that you work with principally. And then in a second, after I go over the agenda, then we're going to put up a poll that is going to ask for that information kind of about how long you've worked in public health and just give us a sense of who we have participating with us today. So back to the agenda here. That's what you can see, and Kat. You see the agenda again? Yep. Okay, super. So yeah, so today is a webinar training on program planning and evaluation. And those are two distinct sort of activities, but oftentimes people meld them together because in order to do good evaluation in public health programming, you really have to be in at the ground floor in public health. To do good evaluation, you have to be on the ground floor in the planning stages. And so that's one of the main reasons why planning and evaluation are oftentimes taught together or clumped together as adjacent activities, but they are distinct in their own ways. And I'm going to walk you through that and what the components are. So Emily sent out this agenda before to you all, so you will have this somewhere in your inbox, hopefully. And if you don't, just ping us and let us know in the chat, and we'll get it out to you. Because the handy thing about this agenda is it will serve as a good reminder for you after the program planning and evaluation webinar finishes today. You'll still have this on hand, and it does enumerate the 10 steps of program planning. And some of the later steps of those 10 pertain to evaluation. So it'll be a good, maybe like a roadmap for you moving forward, and can jog your memory in your own program planning or evaluation activities in your own offices after this. And then toward the end of our second day together, which is Friday morning, we're also going to be I'll also share some resources online that you can look at on your own that pull from CDC or Public Health 2.0 or Public Health 3.0's websites that do have components on there that pertain to this kind of topic. So the way that we have the time together organized today is that we're going to be working through a series of topics between now and 11 or close to 11, and around 10:45 we're going to do a poll that has to do with stakeholders in your community and identifying stakeholders in your community that are going to be affected by whatever program you're planning is an important component of the program planning work. So we're going to be asking you to do a poll at 10:40, and then as a result of what we see there, you're going to then be separated out into separate breakout rooms, which usually have about 5 people in them. And what I'd like to do there is have you discuss with other members of the class what are the kind of programming goals you're working toward or grappling with currently, or thinking about, maybe putting together a program eventually, and who are the relevant stakeholders in your community based on what I share with you there. So that's the first poll. Then we'll take a little bit of a break at 11, and that will give you time to just refresh a little bit, stand up and do what you need to do. And then we'll come back and work through steps 6 and 7, and then talk about theories of change, and then do another poll in a breakout room. We'll end on the end of that second breakout room. And then when we get back together on Friday at 10, we'll begin by revisiting what all you guys talked about in the second breakout room. And the second poll has to do with the extent to which you're familiar with using theory of change and logic models in your own work, and then just sharing that in the breakout room with your other members of your breakout room, and talking about the realities on the ground for you as a public health practitioner in whatever site you're working in, so that we can share amongst ourselves, which is such an important, actually I would say crucial, activity that happens as a result of people participating in these webinars, because it allows you to connect across counties and regions of the state, or the country, if we have people joining from other states, as we sometimes do. And you can learn from each other and think about, oh, she's using that resource or he's using that resource, I need to know more about that, or what have you. And then oftentimes we'll see connections being made between health departments or even states as a result of those conversations. So that's a little bit of the roadmap. And so let's go ahead. I'll stop sharing this, and we'll throw up that first poll. And I just want to jump into the chat myself while Em's putting that poll up, and just see who we have with us today, or a little more about who we have with us. Thanks for putting that up, Emily. So yeah, this is really interesting. So I was sharing with Emily and Kat earlier that we used to teach this class through an in-person summer institute that was hosted by the Montana Department of Health and Human Services. And so everybody used to come together in person for these summer institutes once yearly. And folks who've worked in public health, which I can see from the poll, we have a couple people who've worked in public health for more than 3 years might remember when we used to do that. But we would sometimes have people who, I'd be like 6 hours into the session, and then somebody would say, hey, could you just talk about what public health is even? And so, they would say, well, I was at the bedside basically until last week, and I'm brand new in my position and don't really even know what public health is per se, like what it includes exactly. And so this is not surprising that, nearly 50% are less than a year in this group working in the public health field. And I can see from the chat that we have a number of kind of specialties represented, but some clinicians and nurses and sanitarians and so forth. So AmeriCorps, oh, interesting, Rachel. So this is pretty typical. And then of course we've had a lot of turnover in the state of Montana in the public health ranks. And so that plays a role as well. But we were discussing, Emily and Kat and I were discussing before folks came on, if the rate at which turnover is occurring is starting to slow down. And I still don't have a good feeling for that, but I think it's still pretty high. Maybe people could just turn on their microphones and chime in. Denise, I see your camera is still on. How's turnover feeling where you are?
We have completely, from maybe October of last year, completely started rebuilding our public health. For the last 20 years, it had been contracted through the hospital, and they chose not to renew that contract. So, when we say it's brand new, it is brand spanking new.
Yeah.
So, I mean, everyone in it is 6 months tops.
Yep, got
So
it.
we're
Oh,
learning on the fly as we go.
yeah. Wow. How about other people? Are other people still experiencing high rates of turnover in their departments? Jennifer, I see you're nodding, and Sarah. Yeah.
Yeah. Yeah, I work at Community Medical Center, which is an important partner to public health.
Yeah.
I work in laboratory services, so we often supply a lot of the testing, water quality, infectious disease reporting. And so we kind of interface in a different way. And as Denise suggested, those partnerships are run through private hospitals. And so I think sometimes on the private side, we miss out on the frontline training in public health.
Mm-hmm. Interesting. How about, I'm keen to learn more. Most of the examples that I use in my presentation today are related to COVID and COVID testing. So I'm wondering if that's some of the overlap between you guys. Yeah. Oh gosh, stupid COVID.
Yep. A lot of and a lot of vaccine support too.
Yeah.
You know, and just partner with public health for how private institutions can fortify what the needs of the community are.
That's really cool. I want to learn more about that because it does seem like and that kind of public-private partnership in our state is increasingly important. Sarah Dobson, I saw you were nodding as well. Can you remind us? I don't have the chat pulled up just here, but where you are?
Yeah, I'm with the Gallatin City County Health Department in Bozeman.
Yeah.
So we, have brought on a lot of additional staff over the last 2 years to help with COVID, but I've still seen pretty consistently, I think throughout the 2 years, especially the higher rates of turnover. And that's just our health department, but also across the whole, our whole county staff, other departments as well. I think it's also a trend.
Yeah. And is that just because people are finding higher paid employment somewhere else? Or, I mean, obviously public health practitioners have been targeted in some instances as less attractive as a career path, but is there anything else going on?
Yeah, I think that's part of it. And I think what we're hearing a lot too is the cost of living is just increasing a lot too. So people keeping up with that.
Yeah.
With, the salaries and stuff here, and
yeah,
that's a
for the county
thing too.
Yeah, we're definitely really struggling with that here in Missoula as well. The cost of living and housing in particular is just completely gone off the charts. So
yeah,
we have a very difficult time. So if other people want to chime in on the chat, I'm very interested in this because we're keen to monitor the workforce and what the challenges are, of course, in the higher ed sector and public higher education in our state. We don't compete well with public education in other states in terms of salaries. And then when the cost of living has gone up so much, it's just rippled right across the system here. So we see it also in the county, like you're saying, Sarah, but in the university, it's a huge, huge challenge. So anybody else that wants to chime in their experience on the chat, I would be really interested to hear about what those challenges are, because it also occurs to me that for the Public Health Training Center, it's good for us to know in terms of potential future trainings that we might need to offer that are focused on employee incentivization and retention and things like that, because that is a very real challenge. Well, so I'm going to go ahead and share my screen, which is going to get us onto the slides here. So yeah, okay. So I just was going to say a little bit about my background. So Emily said I work in global health, which is absolutely right. I've done program planning and evaluation in lots and lots of different settings around the world. I did my dissertation research and work to this day in northwestern Nepal on programs that are aimed at helping people in very low resource settings in the high Himalayas deal with some of the challenges, the health challenges that they face there. And a lot of my work up there, speaking of the sanitarians now, has been in the water, hygiene, and sanitation sector. or sectors. And these folks up in the mountains, they don't have indoor plumbing. They still practice open defecation in many of the villages. And so one of the areas that I've worked in there has just been really focused on working across cultural sort of divides, if you will, at getting people who deal with a very different set of realities and a different understanding of disease causality to people in our sort of contemporary American one, or, you know, any really any urban modern industrial setting or in any country. Most people ascribe to the germ theory of disease, and these folks don't. And so that poses a particular kind of form of challenge that people working in global health deal with a lot. And also, in order to work effectively in these settings, and I have also worked extensively in sub-Saharan Africa and in Central America, you have to put together multidisciplinary teams. And working across cultural divides and working across disciplinary divides is all kind of wrapped into program planning in their own ways. And so this actually does relate to the subject of the webinar today. And so I've also worked extensively in Montana in the maternal health sector primarily, but not exclusively. And the cool thing about program planning and evaluation is that this is a set of skills that is the same no matter what setting you're working in. It doesn't matter if you're in the high Himalayas or if you're working in Montana, you know, coordinating between Billings Clinic and the critical access hospitals and the county health departments. Program planning and evaluation is always the same. We follow the same format and the same set of principles. And that toolkit is thusly very portable. And so if anybody on the call has any interest in developing an expertise in program planning, this is really kind of to whet your appetite and get you across the details on like what's out there in program planning and what are the fundamental building blocks of the main program planning approach that is embraced by the CDC, which is called Logical Framework. But we offer certificates through our public health, our School of Public Health here at University of Montana, which are online. And so if you wanted to increase your background and your knowledge in this, definitely check out our website. A little plug there for the School of Public Health. But no, I think it's important because public health program planning and evaluation is such a portable toolkit. And if you like that way of thinking, if you enjoy being very organized and if you enjoy planning, then this might be a career area for you. And there are people who this is their whole thing, is just program planning and evaluation. This is what they do. It's a distinct job title within global health, for instance. And that is particularly in monitoring and evaluation. And so I think it's a really exciting field, and some people think it's boring. I'm not one of those people. I enjoy kind of geeking out on program planning and evaluation, but because a lot of people don't, it means there are lots of jobs in this. So if you like it, then there might be a future for you in this particular sector. So I'm so glad that you're with us today. And I'm going to talk a little bit now about public health generally, because like I was saying, oftentimes we have people who participate in our webinars who are quite fresh to the field and didn't do a degree in public health or haven't worked for very long public health, so don't realize that it has 5 distinct areas, and these areas are recognizable to any public health program basically in the world. So what I love about public health is, in addition to program planning and evaluation being very portable, public health is very portable. So anybody in the world, in any country, knows, or who sort of works in the health sector, knows what public health sort of generally speaking embraces and covers. And so if you come to them with a certificate or a degree in public health, they understand what that means. And so that is really distinct from my old field, because like Em said, I joined public health from anthropology, where I was a medical anthropologist for 20 years at the university before joining public health. Even though I was doing basically public health and anthropology, if I told anybody I did anthropology, they would have a very loose understanding of what that meant exactly. And so I'd often get questions like, so what does that mean precisely that you do as an anthropologist. Public health isn't like that. Pretty much everywhere people know what public health means, but they might not know the details per se. So that's what our certificate and degree programs do, is kind of get you down into the weeds. But so the main areas are on the screen here. So behavioral science and health education is one of the main areas, in addition to biostatistics, environmental health, epidemiology, and then health services administration. So I know we have some EPIs on the call with us today, which is cool. So most people know epidemiology is basically having to do with disease surveillance and understanding that occurrence and prevalence of disease. Program planning and evaluation links together. It's kind of a cross-cutting tool that, or set of tools that you can see appearing really in any one of these 5 areas, but draws from each of them in different ways. So would draw from the expertise of biostatisticians, draws from the behavioral science people and health education people, draws from the environmental health and the health services administration differently depending on what the program is about that is undergoing the planning process. So it's a cross-cutting toolkit, program planning and evaluation, and can draw from any one of these 5 areas or be instrumental in any one of these 5 areas. So going back a little bit in terms of history. So currently, we're in a phase or a period in public health, which is referred to as Public Health 3.0. So you can contrast that with where we started, Public Health 1.0. And so public health really started in the 1800s, back when the famous study of the Broad Street pump was investigated to understand the role of this particular water pump in a major disease outbreak in London that many people probably know about. That study was undertaken by John Snow, who's a famous kind of early public health practitioner and researcher. So when you see on the timeline on the bottom about how this kind of field of inquiry and practice started in the 1800s, this is really back at the time that that epidemic was being investigated of diarrheal disease. And so there was a tremendous growth during the early period in terms of developing the field, its knowledge and toolkit and things like that, with a lot of crossover between medicine and this burgeoning expertise of public health. At that time, of course, in the 1800s, people, depending on socioeconomic status, had very uneven access to healthcare of any kind and also public health. And that inequity still pertains in most societies on Earth. If you look at all of them cross-culturally, that's still true. Among the developed nations, ours has probably the most inequity from one community to the next. And by socioeconomic status, we do see really very substantial disparities between communities, of course, in terms of access to healthcare. Second phase was the systematic, what was referred to on the slide here as Public Health 2.0, the systematic development of public health government agency capacity across our country. And then during that time, the focus of our field was limited to traditional public health agency programs. And then in the latter years, in the phase referred to as Public Health 3.0 here, the emphasis has been on engaging multiple sectors and community partners to generate collective impact, and also investigating and designing programs that target the social determinants of health. So I'm doing a webinar actually in a couple of weeks on the social determinants of health, or maybe that's next week. And so if you're unfamiliar with the social determinants of health approach to public health and you're interested in that, we're doing another webinar similar to this one with two 2-hour sessions on Wednesday, Friday, just like this one. So in the latter phase that you can see on the slide here, there has been less siloing of public health activities and more public-private partnerships, like we were talking about the work between the Missoula City County Health Department and Community Medical Center, for instance, Jennifer's work. And then also, like on the side, just a reformulation of the the way that public health is undertaken, instead of just doing, like, say, for instance, vaccine programs and, you know, immunizing children. Instead of just doing that, broadening out to understand more things about why, for instance, there might be vaccine hesitance in some corners of our communities, and thinking more holistically about how to deal with that reality. So that's more of a social determinants of health approach, and a more cross-disciplinary or multidisciplinary approach that you can see here in 3.0. Okay, so in this slide, what I've done is put together a list of specific issues that I think are germane and are understood across the public health sector as being important for understanding health and health outcomes in rural contexts. And of course, Montana is largely rural to, you know, extreme rurality. And so this is, of course, a big part of what we're dealing with here in our state. So on the left-hand side of the slide here, you can see all of the things that I'm sure you're familiar with, working in public health in a rural place. On the right-hand side of the slide appearing now are some more things that also pertain. In more rural places, you tend to see lower educational attainment and lower health literacy, and some other more kind of social determinants that weigh in and affect the way that people behave. And so I think it's really important for us to understand as rural public health practitioners, and certainly this has been the case in my work in rural Eastern Montana on maternal health, in understanding that the cultural and social differences, stigma, norms, et cetera, are very different from one community to the next. So I think oftentimes people want to imagine, especially people from outside of our state, they want to imagine that everyone's basically the same here in Montana, that, you know, everyone's rural and everyone's basically white and everyone's basically this, that, or the other thing, but that's actually not true on the ground. There are huge differences between, say, for instance, Missoula, Bozeman, and the rest of the state, or Billings could probably be included. But, you know, the overlay on top of that is we have quite a bit of ethnicity in our state. We have, of course, a lot of Native people. And then we have, within the non-Native people, we have groups that are quite different to one another in terms of cultural and social norms, like Hutterite, Mennonite, fundamentalist LDS communities, and so forth. And each of these different communities can have different, and does have really different health challenges. And so one of the things that it's important to understand in our program planning work is the significance of recognizing and understanding those differences and tweaking our programs so that they are unique and uniquely suited to the circumstances in which we work. Okay, so what's good about a plan? Well, program planning is really, really important. They allow us to focus on what our priorities are. They link activities to your department or your office's strategic plan. And if your office or department doesn't have a strategic plan, that might be a good starting place for you to kind of focus on and investigate, like, why isn't there a strategic plan and what might go into that? But if you do have a strategic plan, then program planning for specific initiatives you're trying to target should link up to your strategic plan. Plans will formalize your efforts and organize them. They set our expectations of ourselves and our colleagues in our offices, and give ourselves timelines by which we're going to hit particular goals, ideally. And they also define roles and responsibilities so that everybody knows what they're doing and when they're doing it. And they help us measure impact, and they validate our programs. And in an increasingly competitive funding environment, being able to measure and validate program effectiveness is increasingly important. And then last but not least, they provide continuity through change. So if you have a plan that's guiding your work and guiding your activities and organizing you each time you get to the office, then it gives you some through thread. Do you know what I'm saying? When things are tough, like you're dealing with a disaster or you're a pandemic or what have you, the plan gives you kind of an anchor to keep you organized. And so I'm a big fan of the planning. not just program planning, but also strategic planning for the whole team. Okay, we also have in public health a very heavy emphasis on using evidence-based programs. And so program planning and evaluation both link up in different ways to evidence. So program planning draws from the evidence base that establishes why a particular initiative or why a particular intervention is effective and in what ways it's effective in different circumstances. And so if you are getting ready to do, say, for instance, do a new approach to tobacco cessation that has not been used in your area previously, you can go out and look at what's the evidence base for taking this new tack to tobacco cessation in other similar settings to the one where I work. So program planning pulls from the evidence base in that way. Program planning is also followed by program evaluation. So evaluation adds to the evidence base, meaning you did your program, you monitored it effectively, you evaluated it effectively, you chose good metrics, and then you measured activity outcomes against those metrics. Now you are contributing to the evidence base. So evidence base is obviously it's where it's at in public health. If you're not drawing from an evidence base or contributing to an evidence base, then people are going to look askance on what you're doing and wonder, are you sure that you're doing it are you sure you're using time and energy and also resources as effectively as you can be? So in terms of the evidence base, then what we see is that the evidence base out there in the existing literature, it does already identify for us key areas of need and interest, and that can help guide us as to what programs we might select or initiatives or interventions we might select to begin in our areas or our regions. And then the evidence is out there in the literature of all kinds, programs, policies, environmental supports, health benefits, and things like that. And the evidence also supports outcomes evaluations, which is the kind of second half of our webinar that we're going to get to on Friday. It aligns or should be helping align resources and infrastructure, the evidence base should. And every evidence-based program that you involve yourself and your team in should always start with a good mission statement. So this is kind of like launching into the nuts and bolts of program planning. Okay, so when you're getting ready to plan a new program for your team or your office, you want to start out with a good mission statement, and usually 2 or 3 sentences should suffice. So in order to get to your mission statement, you need to be asking yourself the right questions. The right questions are basically 4, and they're who, what, how much, and when. So the first question is who? Who are you targeting with your particular intervention? And your answers to that question should be very concrete, very specific. If you are too general in answering question number 1 here, who you're targeting with your new program or initiative, you can introduce measurement problems. If you can't measure the efficacy of your work, it impedes your ability to validate and then justify your program for further funding. It also limits your ability to generate new evidence to add to the evidence base. And so being very specific in answering these 4 questions is critical. Okay, what is the second question? Identifying what you want the people to do in your program. Again, here precision is the key. And so then that brings you to, from the what you want them to do is the question of how much you want them to do the thing. So in other words, how much do you want the behavior to change? And again, precision here is the key. So when you're talking about how much you want a particular behavior to change, you should include statements like from X% to Y%, or from 10 people to 20 people, or like at least 30 or no more than 10% are going to be doing X behavior anymore, etc. So again, if you are imprecise with question number 1 about who you're targeting in your new initiative that you're planning, you cannot answer question 3 because you can't measure a percentage if you don't know what the denominator is. Like if you don't know the number of people that you're, supposedly moving the dial on their behavior, like tobacco cessation behaviors, then you cannot be precise in terms of where the dial is moving from and to. So the how much question kind of builds on your answers to the previous questions. And then the when question is also really important in terms of program planning. All program plans should have precise timelines because you want to cap the activities at a particular point in time at which you're going to be measuring the impact of the program. And so it should be, the timeline should be specific and it should be bounded, but it also should be reasonable. So for instance, you don't want to overpromise, like you're going to move the needle from here to here in too short of a time period, because then you're probably not going to achieve the thing that you said you were going to, and then that makes your programming look ineffective. And so being very considerate and mindful of how slow change is in reality, I think is very important here. And also, you have to be realistic and reasonable. You don't want to set the timeline so long that you have so much turnover, staff turnover, say for instance, where we started our conversation today, that you don't even have the same people at the end of the period that you started with. So that would be no good either. Okay, so then that asks us to look at specific objective statements. Like for instance, here's an objective of a health assessment program. And the objective statement was, our objective is to increase participation in the health assessment. So does anybody want to turn on their mic and volunteer some reasons why this is not a good objective statement in terms of the 4 questions, the 4 right questions from the previous slide?
So I think it's too vague, lack specifics.
Absolutely. Yeah. This is, overarching, like if you're chatting with somebody over cocktails, sure, like you can say a statement like this and you'll convey to whoever you're talking to, like what the gist of your work is. But in terms of programming or program planning and trying to get funding, or for instance, or trying to keep your staff members on task, it's not going to cut the mustard. So it doesn't have any who statement. It doesn't have a very good what statement. It doesn't have much of a how much or by when statement. So a better reformulation of this that would be more effective would be something along the lines of this. So residents of a particular neighborhood will increase their participation in the health assessment, but precisely from 30% of households moving up to 50% of households, and that this is going to occur by the end of a particular year. So that kind of precision is what I'm talking about here. Okay, so the next thing that I wanted to talk about is action planning. And after this, I'm going to segue into specific program planning models. So action planning is basically a term that we use to refer to detailed planning for activities that support program objectives. And they need to have the following 5 pieces. The first is clarity around roles and responsibilities. The second is a timeline for each activity. The third thing is identification of what financial and non-financial resources are going to be needed. And the fourth thing is communication strategies. So any decent public health programming initiative should have, as part of it, some kind of definition of how you're going to communicate about the program to your stakeholders in your community. And we'll get into detail on each one of these things as we go through the training today and on Friday. And then the last piece is data sources and evaluation strategies. Okay, so the next thing that I wanted to do is talk about a couple of different models for program planning. And I'm going to talk about two that we are not going to use. And then the third one is the one that we are going to use, and which is very commonly used across our industry. The first one that I wanted to at least just expose you to is called the Getting to Outcomes model. This came out of RAND. And basically you can see on the schematic here that it starts out with some of the things that I've described to you already. So looks at needs and a resource assessment. Second, moves to identifying goals and desired outcomes. Third, look at the best practices from the evidence base. 4, look for the fit with the community and the population you're working with. 5, capacities on your team and locally. 6, plan. 7, evaluate the process. 8, evaluate the outcomes. 9 is continuous quality improvement, so a feedback loop to make sure that you're constantly looking at and measuring your progress toward stated goals. And then last is 10, sustainability. So this is a like log frame or logical framework, which we're going to really do the deep dive into together. This is a 10-step process, and it's an iterative process in that the steps loop back on one another, so that you're never just, it's not linear. You're always circling back and looking at ways that you can improve and make tweaks along the way. And all decent program planning has that iterative feature, that you're constantly going back, making mid-course corrections and tweaking things within some boundaries. I mean, obviously you can't tweak things so dramatically that you're now doing a different program altogether than you started with. You can't start on tobacco cessation and then move toward a vaccine program, for instance, in the same program planning. But some mid-course corrections are always appropriate, and all planning approaches have that feature. Then we have pre-seed and proceed models, which are called PPM, which we also teach about in some of our classes here in the School of Public Health. And I just wanted to expose you to these and note that proceed was the first one that came out, and then pre-seed came after it. And proceed, let's start at the bottom. It has these 4 components: implementation, process evaluation, impact evaluation, and outcome evaluation. That's one way of doing the program planning and evaluation package altogether. Then the pre-seed model came, it superseded proceed. And what it did was it added in some new perspectives or frameworks. It looked at not just any old kind of assessment or evaluation, but specifically social, epidemiological, and ecological assessments. So it just kind of shifted the lens, that people were like looking at the problems, the health problems through. So basically what's happening in the pre-seed iteration of these planning systems is it added in a social determinants of health framework to look more broadly at whatever was affecting, say, for instance, if you're doing a pre-seed approach to SUD, substance use disorder, the argument here would be a decent program plan would include social, epidemiological, and ecological, like looking at the socio-ecological circumstances that people live in. You can't do decent program planning if you don't consider those factors. So it shifted the perspective a little bit. We're not going to use either the RAND model or PPM models in our program planning work, but I wanted you to know that they're out there. Okay, so log frame or logical framework is the model that we are going to be using. And I'm just minding the time here and just wondering if it might be coming up on time for our first poll, but I'm not quite there yet in my slides. So you might be wondering, why is it 10:45 and she's not doing the first poll? So let me pop out of this screen here for 1 second and to that poll later than I thought is the moral of the story up to this point. Okay, so I'll just keep going, but I promise we'll still break at 11, I promise. And if you have had as much caffeinated beverages as I have this morning, I'm sure you're going to be happy to hear that I will be making a break at 11. Okay, so log frame.
You're in display mode again.
Ay, ay, ay. Display settings. Is that better?
Perfect.
Yeah. Okay. So I'll scroll right down to the bottom here. So log frame, it actually came out of an international development, the international development world, and then we brought it over into public health domestically. So it was developed in the late 1960s for USAID. USAID is the branch of our federal government that, you know, lots of people will be familiar with that does development related activities in other countries. So they rolled it out in 30 countries in the early 70s. Why did they do that? They did it because we were spending a bunch of federal monies on development projects in different communities and nobody knew what was happening. Like we didn't have a good systematic framework to use that everybody would be using the same framework to understand what the outcomes of the programs that were being funded with our federal tax dollars were. To this day, it's still used. It's very popular worldwide. Pretty much any Ministry of Health of any government in the world is familiar with log frame. It's widely used CDC programming in this country as well. You can boil it all down to the matrix, the log frame matrix, which is a 4x4 project table, which we're going to spend some time on in a few minutes. We'll probably after the break. And it really looks at what assumptions you're making, and it really makes you scrutinize as a program planner. What assumptions are you making that might be bad assumptions? And those assumptions have to do with what are the external positive and negative influences on your ability to achieve your program ends. And are your assumptions substantiated? In other words, from the evidence base? Are you assuming something on tobacco cessation, for instance, is going to work in your community based on the fact that the evidence shows it's worked over here in this other community that's similar to your own community? So this is a very common kind of assumption. The evidence base tells you something about how well a particular program is going to work in your community. And the log frame approach assumes that you are going to develop a program plan that doesn't have a killer assumption. And a killer assumption is an assumption that is, if it's invalid, it's going to have a major negative consequence on the outcome of your project. So for instance, a killer assumption to most COVID planning for rolling out COVID vaccines was that public opinion was not going to turn against public health practitioners in the way that it did. That was not a good assumption in the end. That did play a big role in our ability as public health practitioners to interact with people in our communities. And so that's a new kind of killer assumption that we all need to be aware of in all of our program planning. We can't just assume that people are going to, that people's uptake of our program is going to be simple or unproblematic. And so that would be a good example of a killer assumption. Okay, the log frame pieces has, the pieces includes the following. So we have stakeholder involvement, and that's the subject of one of the polls that we're going to be doing today. It's asking you to think about stakeholders in your community that you're going to or are already interacting with. The other feature is that a log frame takes a needs-based approach. In other words, we're reacting to specific needs in our communities. It is logical in the sense that the log frame is based on a series of if-then statements. If this happens, then we expect this to happen. It gives us a framework for assessing relevance and feasibility and also sustainability of our programs. It's results oriented, not activity driven. And so a little bit later in our time together, when I'm talking about evaluation, I'm going to be talking about how there is a difference between monitoring and evaluation. Monitoring is looking at whether or not different activities occurred, like you ran X number of trainings. Evaluation pertains to what was the result of those trainings that you ran. And so that's a results-oriented approach, not an activity-oriented approach. So some program planning and evaluation approaches are very focused on just figuring out, did the activities promised get done or not? Log frame asks you to take a step back and say, yeah, not only did we do the activities, but we built in some metrics that help us assess whether or not those activities were good and changed health outcomes. So that in that way, it's results oriented in terms of the health outcomes, not just activity oriented. It sets objectives and then it describes the causal relationships between objectives. And it shows using indicators that you select as the planner. It shows whether objectives are being achieved. And the art and science of program planning is in choosing metrics or indicators, that those terms are interchangeable, that are the right ones. They determine, they are linked to program objectives and activities, and they tell you whether or not those activities got done, and they also tell you what the outcome in terms of health as a result of those activities getting done were. And then last but not least, the log frame approach, it describes external factors that influence the project's success, and those are the assumptions and risks that I was talking about previously. Okay. So now we're up to 11 o'clock. And so I'm just going to stop there. And when we come back in 10 minutes, I'll start talking about the log frame matrix, which is also referred to as the log frame 4x4 table, which is the heart of the log frame program planning approach. So it's now 11 o'clock, pretty much on the nose. So let's take 10 minutes and reconvene at 10 past the hour. So we're back. Welcome back, everybody. All right, so I left off with a kind of a teaser that we're going to look at the log frame matrix next. And so here are a couple of features of log frame matrices that are significant. So this is the main output of using the log frame analysis approach. And so this is a matrix that's used to present information about objectives, outputs, and activities having to do with your project in a systematic and logical way. And it's a 4x4 matrix, like I mentioned before, 16 cells organized into 4 columns and 4 rows. So those look like this. So I love log frame matrices because they really keep me organized. And I use them a lot. So along the top are the labels. So on the left is narrative summary that basically says what you're doing down the first column. Next is, what are your objectively verifiable indicators? What is the means of verification of knowing that those indicators are good ones? And what are your critical assumptions? So down the left-hand side here of the leftmost column, it's best to read this from the bottom up. So a project has inputs. Those are basically like activities. And it has outputs that flow from those. Those link up to the project purpose. And then ultimately, all of those things feed into the highest level project goal. So let's look at what that practically looks like. Basically, this is the logic behind a log frame matrix. it flows from left to right. So the assumption here is you make a particular kind of an input. If that input is made or accomplished, and this critical assumption is appropriate, then it will result in the following outputs. And you can zigzag back and forth across the schematic with each growing level of the matrix. So let's populate the matrix and see what that might look like. In order to do so, though, we have to begin our log frame steps. Okay. So the log frame steps are the 10 steps I referred to when I was going over the agenda with you all. And the first step is defining the problem. In order to define a public health challenge, you need to walk yourself through 7 sub-steps. Those sub-steps are as follows. First of all, you have to know what is the population age and sex structure that you're supposedly targeting with your program. Second, what are the morbidity and mortality stats? Maybe only morbidity stats are appropriate, maybe mortality stats are appropriate depending upon what your program is aimed at. If you're aiming at changing maternal mortality, then obviously you want to know what the maternal mortality stats are. If you're interested in changing, say, for instance, instances of smoking-related disease, then morbidity stats are where it's at. Second or third, you need to know the epidemiology or incidence, basically, and prevalence, and then the geographical distribution of the problem. Are you talking about a problem that occurs only in a very specific community? Like, for instance, some Hutterite people and communities have some different kinds of incidents of some genetic diseases that relate to the way that they intermarry in that community. And so then the geographical distribution of the problem is extremely specific because it's limited to the borders of the Hutterite colonies in question. Other problems have much more porous borders, theoretically, so it's good to take some time to think about, like, specifically how you want to geographically define problem you're working on. And if you work for a county, then that becomes a bit easier because you're working on it within your county. You also want to know what facilities are available that you might partner with or get information from, et cetera, to tackle your problem and begin the program planning about it. What's the available person power, both on your team and in partners? What kind of training facilities and capacity exists? And then last, what are the beliefs and attitudes in the community that you're targeting toward health, disease, and cures, and preventions, and the like? So again, if you're working with Hutterite people, then it's really important, for instance, to understand that their way of understanding disease and health-seeking behavior might be really different to other communities that you might work with across the state. Okay, so additional considerations might be like things to do with what constraints or limitations you might run up against: technical, economic, social, cultural. What other existing solutions have been used in your particular area, like maybe by the person who worked in your job before you, or several people before you? Has anybody worked on this before? What was the outcome? So it's always good to kind of look at who did what when. Has anyone worked on this before, and what was the impact of that? And then, of course, thinking about potential setbacks. So, like, if you want to think about the COVID-19 testing, which I know a bunch of you have been actively working on in different capacities, either clinically with the hospitals, like in some cases mentioned before, or using resources available through the health departments, for instance, you're going to know all about the COVID-19 testing realities. So I use that as an example here over the past couple of trainings, just because it's so prevalent in everyone's minds. So the considerations are on the left column, and the type of metric that would be appropriate to understand the realities of that problem, or use it to use as a way of measuring progress toward dealing with the realities of pertaining to a particular problem. That's in the right-hand column. So these are additional considerations and how they pertain to measuring problems and the result of your interventions. So you can see here on the left, I put, like, for instance, utility of the intervention and prevention, diagnosis, or treatment, economic feasibility, durability, sustainability, ease of use, and adherence to quality and safety standards. So these are some additional considerations that you might have in mind as you go through your program planning process. I put in some types of metrics in the right-hand column just to kind of give you some ideas and help you think about how you might measure, say, for instance, sustainability. It's kind of a flabby word and a flabby concept, but if you make it concrete in the way you're going to use it, then it can become quite useful. So I put in the right-hand column some examples of how you can devise metrics to help get you where you need to be in dealing with these additional considerations. Okay, and I did notice that somebody asked in the chat if we were going to share the slide deck, and we are going to make that available to people. So if you want to refer back to this material, if you feel like it's moving along at a quick clip, then you're going to be able to do that later. Okay, so needs assessment is step 2 in the log frame approach. So it helps you identify issues and where and how resources are going to be best used. Needs assessments also identify factors that impact health outcomes and in particular health systems. These should be evidence-based and problem-focused as discussed prior. And data from the appropriate population or subsample of a population can be collected in a variety of manners. You could use surveys or questionnaires or focus groups, meetings, observations, and interviews. Or you could pull from existing databases of demographic data or vital stats, hospital records, and other people's reviews or other people's work on similar problems in similar areas, regional areas to where you are. So a needs assessment should be data-based and data-oriented. Okay. You might be wondering, well, how do I do a sample of a population in order to know that I'm doing a needs assessment of the right individuals or the right, say, for instance, facilities? And there are lots of different ways to do sampling, and we teach that in our research methods courses here. It's a little bit beyond the scope of this particular webinar, but I did want to at least expose you to some terms that you can investigate on your own, or maybe think about studying this more down the track. But if you're not going to collect information from everyone in your community, therefore you're not sampling, you're not taking a sample of the community, you're doing a complete survey of everyone in your area or every facility in your area, depending upon where the needs assessment is based, you know, what's the unit that you're sampling, then you don't have to worry about sampling. So if you're doing a needs assessment of all, say, clinical facilities in your area, then you're not sampling, you're doing all of them. But if you have too many people in your area that you can't contact all of them, then you can subsample, or you can sample or subsample the population. That's what I'm talking about here. And so some examples of sampling strategies are random samples, where you randomly choose using you assign every household in the area a number, and you use a random number generator, and you pick only those households identified through the random number generator as a way of constructing a random sample. You could do a purposive sample where, say, for instance, you only sampled a particular neighborhood within your whole region. You could do a stratified sample where you know that you want some people of low socioeconomic status, medium socioeconomic status, and high socioeconomic status to appear in your sample. That's called a stratified sample. But in order to decide sampling, you have to think about the effect size that you're aiming to measure. And also you need to think about the contact method that you're going to be using to contact people that you might potentially include in your sample. So these are questions and sort of methods that are, like I said before, beyond the scope of this webinar, but I just wanted to bring your attention to them and have them in your notes so that you can come back to this later and make sure that you're understanding the difference between sampling and gathering data from the entire potential universe of units. Like all smokers in your county or all health facilities in your county. Like I was saying before, that would be an example of sampling the entire universe of potential beneficiaries to your project. Okay, so moving on, we come to step 3. So step 3 is crafting the mission statement, and crafting mission statements is a really important thing to do, that you're basically developing like an elevator speech. Like I said before, it should be 2 or 3 sentences. And this is going to be appearing, say, if you're writing a grant proposal, and part of the grant proposal includes your program plan, your mission statement should come toward the top of the grant proposal. And its function is to draw attention of your clients or of your colleagues or potential funders. And it's got to be short. Think of it as like an elevator speech, or the amount of description that you can give on an elevator ride between a few stories. And it really is going to, working on this, I should say, is really going to help you narrow your own focus. And it also ultimately should help grab your listeners' interest or attention. And so, say for instance, it should be also a bit more precise than a very, very general statement would be, you know, less attention capturing. Like, I want to eliminate diarrheal disease. If you say that that's the mission of your project, people might roll their eyes and be like, okay, that sounds awfully broad. But if you state your mission more precisely, like, our project is aimed at reducing diarrheal disease in Ward 1 of the village from 80% of household members afflicted with diarrhea at least once monthly to 20%. Then it's like, oh yeah, I can really sink my teeth into that. I really understand what your project is about. And gosh, also that sounds actually like achievable. Like, you know where you're going in the village, you know what the rate is currently, evidently it's 80%, you know what you want to get it to, evidently that's 20%. And so that becomes like way more catchy as a mission statement. So to kind of continue the focus on COVID, an example of a mission statement pertaining to COVID-19 testing would be your mission is expanding COVID-19 testing allows infected people to know they should avoid social contact as well as contact tracing. And this allows a more precise and cost-saving strategy than long-term social distancing or stay-at-home orders. So that's kind of the beginning of a decent mission statement, having to do with grabbing people's interest about COVID-19 testing. Why is it relevant? How does it focus in people's attention on the importance of testing, and why it's better than other things such as simply social distancing? Okay, so steps 4 and 5 to the log frame approach include identifying your stakeholders and understanding their perspectives. So step 4 about stakeholders is basically a process in which you are thinking about how to engage possible partners. And so those possible partners could be things like community organizations, that would include, for instance, state, tribal, county, local governments, or educational institutions, and people working in healthcare, maybe health ed centers, health advocacy groups, and fitness centers. So you need to think broadly in public health, of course. You know, you don't want to just limit it to certain kinds of healthcare providers, because in reality, people's behavior makes them interact with all kinds of people who are at least adjacent to health behaviors and health outcomes. Like in fitness centers, like a lot of people get, as it turns out, health advice from fitness instructors. And so, or maybe, you know, a lot of people get, especially in rural places, they get a lot of advice from pharmacists. So it's really important to think very realistically and sometimes really outside the box about how people behave in your community. And engaging possible partners is really key. Possible partners in your work that are identified through looking at your stakeholder analysis can achieve a lot of different goals that are going to advance you toward your program planning outcomes or your program's outcomes. So that's why it's an important part of program planning. So partners can be expected to do lots of different things, like they could be advisors or they could champion your program for you. They can offer expertise and insight in their area. They can help you demonstrate that your program, demonstrate to the community members that your program is transparent, and they can help you share information or materials or results. And in doing so, that can really help towards building up community trust in your program. They also can help you establish an action plan that's a realistic one, given community realities and constraints. And they can share the responsibility for planning and implementation and evaluation of programs, like doing program planning and execution of programs, and also evaluation of programs in a partnership with stakeholders can not only make the work move faster, but it also it means less work for your own team, but it also builds community buy-in to what you're trying to do. So it's moving us, really kind of thinking back to that public health 3.0, it's moving us as public health practitioners out of a silo where it's just people in public health and getting us to program, plan, and execute and evaluate in partnership with other people in the community. And it's all for the greater good. It also helps, like, getting stakeholders on board and understanding them helps ensure cultural relevance. And it helps demonstrate and establish agreement with and understanding different people's roles and expectations within the network, like involving people in the program planning helps with that. And that's so important because not only does it get back to the roles and obligations and timelines piece for all of the people who are participating potentially, but it also makes sure that you are not inadvertently excluding somebody from your program activities that would feel maybe offended that they didn't get included because there might be people in your community, for instance, who are already working on something that's either overlapping completely with your program's outcomes or planned for outcomes, or they're immediately adjacent to that. And then you, by excluding them, you can cause offense or duplicate activities in an unnecessary fashion. So all of these considerations are so key. And then getting the community buy-in also means that more people are going to come to community meetings or receptions, forums, events, conferences, etc. And it makes it more just collegial across the board. And so that's all for the greater good as well. Okay. Oops, I have a repeat slide. Okay, so stakeholder analysis is step 5. And so this is like the step beyond identifying stakeholders and engaging with them, like was identified in the previous step. But it is getting you to think about kind of like what I was just talking about before, of who's doing what and what stake might they already have because of their other either personal interests or professional activities in the outcomes of the program that you're planning. And so there are a series of questions that you would want to ask yourself in your stakeholder analysis. So for instance, who's affected positively and negatively by a project? Who has the power to make it succeed or fail? Who makes decisions about money? Who are the suppliers of the products that you need to get the work done? Who are the end users or beneficiaries of your project? Who has influence over other stakeholders in your community? So important opinion leaders, for instance, in your community are very important to bring on side or bring on board. Who could solve potential problems with the project? Who is in charge of assigning or procuring resources or facilities, and who has specialist skills that could be crucial to the project outside of your own immediate team? And so types of stakeholders would be like users. Those are community members who are going to benefit, or sometimes you refer to them as beneficiaries. Governance, so any kind of management board or auditor, regulator, health safety executive, county commissioners, etc. Influencers would be people, like I said before, opinion leaders. So people who have the ability to change the direction of the program inadvertently, like even outside your planning process. Like maybe somebody from the local newspaper or a union. Other opinion leaders might get an interest in what you're doing and change the direction of the project, maybe in a good direction that you want, but maybe in a direction you don't want. And so those are your influencers. And then you have your providers. So that would be anyone who provides services, resources, or other critical needs. Okay, so the stakeholder analysis is to identify needs and interests of all potential stakeholders. What are the organizations or groups that should be encouraged to participate and at what stage? What potential risks are out there that come through these different stakeholders that could put the program that you're planning at risk? And then what are the opportunities in implementing a program beyond, what are some sort of next steps that could result from doing the program that can be seen as opportunities? Okay. So if we're looking at stakeholder analysis, we typically would want to organize stakeholders on a schematic like this that puts power on one axis and interest on another axis. And so I've arranged these 4 kind of types of stakeholders here just to kind of get your thoughts flowing. Or 3 actually, I kept public on the bottom. So public power tends to be low in comparison with politically powerful decision makers and DPHHS. And public interest can vary. So public interest can be low or high. We certainly saw that during the COVID-19 pandemic, that some corners of our communities were exceedingly on the ball, interested in engaging in COVID-19 testing, and other members of our communities really like not just low interest, but antithetical to any kind of COVID related either testing or vaccination or so forth. And so you, in undertaking a stakeholder analysis of the potential either partners and collaborators or people in the community that have a stake against your program succeeding, it's, I think, very useful to put those stakeholders, at least in your mind, if not on paper, on this kind of these kinds of continuums, looking at how high their interest is, how high their power is, and then planning accordingly. Okay, I'm just going to pause here, partly for questions, and check the chat and make sure nothing's come through. But oh, I'm seeing Kat saying no questions in the chat. And then we'll go to our first poll in our breakout room. So the first poll is going to get you to think about who would you expect your community's most important stakeholders to be in terms of community health. And so we have a poll devised that we can put up on the board here. So go ahead and tick which of these you would expect to be important stakeholders in the work that you do in the community that you work in.
And Kimber, this was set up so they can only choose one.
Oh, darn. Okay.
So maybe the most important, and then we can discuss if there's others or.
Yeah, so what we might do is just leave it to the discussion, the breakout room, for people to say, I actually would have chosen these other things as well. And here's why. Okay, so let's put people into, we have 15 participants. So let's do 3 rooms of 5 each. And in the breakout room, I would be interested in you just first of all, getting to know one another. We'll take about 10 minutes here. So who are your key stakeholders and what needs and perspectives do you think they have? And I'm just interested in hearing if this varies a lot within and between communities in the way that you guys are thinking about it. So you might have more than one person from the same county, and each of you may have a different perspective on this question. So let's actually let's do like 7 minutes in the great breakout room, and then we'll come back and we'll do kind of a round robin, and we'll hear from, if each breakout room could please choose one person to be their spokesperson, that would be effective moving into that round robin discussion. So let's hear from group one. So I've lost my, aha, here it is. Okay, so this is entitled Sarah Hauser's room. Who was your spokesperson identified?
Is that
Was-
our room?
This is the room with Brandy, Cheryl, and Denise in it.
Oh.
Is Denise still with us?
Yes, I am.
Are you, would you want to be the spokesperson for your room?
Sure.
What did you guys come up with in terms of stakeholders?
2 were community members and 1 was nurses, doctors and clinics.
Yeah,
But yeah, majority was community membership.
yeah, okay. And no local like opinion leaders outside of those kinds of roles that people came up with as potentially either advancing or working against public health programming?
No, we did not.
Yeah, yeah, okay. So you had then clinicians, and what was the second one?
Community members.
Okay, so like supposed beneficiaries.
Yeah,
Okay.
the beneficiaries were, yeah.
Yep, got it. Okay, so let's switch over to the second group then. This is entitled Sarah Black's room, that has Sarah, Jennifer, Nina, and I think Mary, but I'm not sure if Mary had stepped away. So did you guys have a spokesperson?
Yeah, I'm going to be the spokesperson,
Yeah.
which is cool because apparently it's my room.
That works.
Yeah. Yeah, Mary wasn't in there. I come from a clinical nursing background. Nina is in licensing, and Jennifer there, sorry, is from the laboratory at Community, correct? And so Jennifer and I both get a lot of perspective from medical community doctors, the hospital, and Nina has a lot of interaction with businesses and business owners.
Interesting. Yeah.
And we talked quite a bit about like, kind of going into COVID, what we were expecting, and then what kind of surprised us, which you've already kind of touched on about the, like, resistance to what, it used to always be, especially from like a medical perspective, like, you make this recommendation and the patient or client is like, oh, sure. And there was a lot less of that.
Yeah. Yeah.
And just Nina and Jennifer, do you want to add anything to that I missed?
No, I think Nina brought up a really interesting point that we hadn't, that wasn't immediately obvious to either of us working in primary healthcare. She needs a lot of buy-in from county commissioners and business owners, and she has to bring a lot more people to the table to participate in conversations around what's best for public health. So I think that was an interesting perspective that we hadn't really considered.
Yeah, I'm so glad we have Nina in this group, because that is so important, and increasingly, especially with the pandemic, because there were some like legalities and things like that. So we really had to get the commissioner, like, understand from the local and state government, like who could occupy what role in terms of either, enforcement or, compelling people to behave in a particular way, shutting down businesses that did not comply, etc. Obviously got very complicated very fast. So that's so interesting to have Nina on. So thanks for sharing that perspective. What about if we switched over to other Sarah Dobson's room that had Katie and Robin and I think Geneva as well, if I said that name, Geneva's name right. So who's your stakes person or spokesperson? Stakes person.
Yeah, I can share for our group. Between the four of us, I think we had a good amount of overlap with some of our key stakeholders. So like hospitals, nonprofits, community foundations, schools, the state agencies, state health department, some other professional agencies. I think one was like a nursing association, and then universities and some specific program areas within the universities. And I think that's pretty much it.
Yeah.
County commissioners to health departments.
So Sarah, remind me, are you in Bozeman?
Yes.
Yeah. Okay. So that's pretty typical, like that amount of variation that we just heard between the three groups. I'm guessing the first group was comprised of people who are in maybe smaller communities or counties that don't necessarily have like a university or whatever, you know, that some of those stakeholders that came up in your description, Sarah, or, you know, some communities where there's either no hospital or just a small critical access hospital or what have you, like there might be other stakeholders out there, but they don't involve themselves or their stakes feel like low enough that they don't get involved in any way in public health programming. So it's really interesting to hear the amount of variation between groups, I guess, is what I'm getting at, and I'm trying to account for that. I think it has something to do with the way that the counties themselves are comprised and the different groups. So thank you for sharing that, you all, and for considering that in this step of this process that we're working through here, this log frame process. Oh, I was just noticing there's some stuff in the chat, but it's just about how the breakout rooms were being assigned. Okay. So let's click back over to our slides here. And so we'll move on to steps 6 and 7 before breaking for today. So we had another poll and breakout room planned after this, but we're gonna end up using that to begin our session on Friday, and we won't be doing that today. So step 6 is the SWOT analysis. This is the log frame step 6, just to reorient you to where we're sort of up to in understanding the 10 steps of a program planning approach using the log frame framework. So SWOT stands for strengths, weaknesses, opportunities, and threats. And so this kind of tracks with a lot of what I've shared already about the general perspective that is used within log frame. And it's just the step of the process that really focuses you and your staff members' attention on talking through what are the strengths, meaning what are the positive internal attributes of the program team? What are the weaknesses, negative internal attributes, like maybe missing capacity? What are the opportunities, external factors that could improve program team prospects? And then what are the threats, the external factors that could undermine? And what I wanted to mention at this point is in all of these steps, like this might, it's possible that in the document that is the outcome of a program planning exercise using log frame, that some of these steps don't appear. Like it's not in the program plan that you would maybe submit to a potential funder. Maybe you wouldn't include word by word every single step, but you should engage in every single step together with either yourself, if you're the only member of your team, or with your other team members, just to be pausing and spending a little time thinking about each of the topics that is addressed in each one of these steps. At the outcome of it all, like you've written a beautiful program plan. Like I said, either some of the steps might not appear at all, or they might be very short. Like you might have a couple of sentences that refer to the fact that you did a SWOT analysis, or some of the upcoming steps along the way, but it might not, your program plan, the written document that follows from using a log frame exercise, it doesn't have to have every single one of these 10 steps, but as a team, you should talk through each one. So in terms of COVID-19 SWOT analysis, you know, the purpose of doing this is to really sort of assess the performance and capacity with respect in the example that I'm using in this webinar of COVID-19, like what is the performance and capacity of participating units or division or organization, divisions of the organization that you work for vis-a-vis, in this instance, COVID testing. Each one of these units should ideally undertake a SWOT analysis to their own self. And really, this is like it's a tool that we can use. Again, this doesn't necessarily appear in a program plan, but it's a step along the way to get you to think critically about what do you have available at your fingertips on your team. And also, what are some of the threats to what you have available in terms of maybe you might lose people to either sickness, or maybe they're going to move somewhere or leave the job or what have you. Those are the kinds of typical threats we would see being considered in a SWOT analysis of this kind. So making it more concrete then, so I have on the left-hand column here, this is an example of a table that you could work up together with your team in doing your SWOT analysis of your unit or your whole team. So the strengths, weaknesses, opportunities, and threats are on the left. And then, so for like say a COVID-19 testing scenario, some of the strengths might be, you know, personnel or partnerships with the DPHHS, with local, county, tribal health or infrastructure. Maybe the Rocky Mountain Biological Lab here in Western Montana, maybe Rocky Mountain Bio, which is an example of a private for-profit that developed COVID-19 testing capacity. Maybe institutions within the Montana University system. There were lots of labs at MSU Bozeman that were doing this kind of work. There were lots of labs at UM doing it. Then strengths would be like public interest and public cooperation on the one hand, on the one side of the coin. On the other side of the coin, there's, you know, the elements in the public that ended up more in the threats category. Weaknesses would be like coordinating and messaging. Opportunities would be linking strengths that are listed above, or business growth, as in the Rocky Mountain Bio, and looking ahead to prevent future disruption. These are the kinds of opportunities that are like the silver lining, I suppose. And then the threats below would be like all the things that we've collectively experienced as a society: economic, supply chain disruptions, and misinformation and disinformation and that kind of thing. Okay, so we're right on 12 noon, and because I want to respect your time, and knowing that we have more time together on Friday from 10 to 12, I think I'm going to pause here. And the next thing I'm going to talk about is theory of change and the logic model and the problem tree elements to doing log frame. And that's going to kind of propel us forward into the next group of polls and breakout room discussions, which is to just hear from you about what program planning experience you've had in the past and whether or not you use log frame or some other approach, just to help us and each other understand what our experiences collectively as a group have been in that regard. Okay, so just a little teaser for next time we get together. We'll start with step 7 out of 10 steps, and then we'll move into the evaluation portion of the webinar. All right, well, we're out of time, so I will be stopping here at the top of the hour, and I will see everybody hopefully on Friday morning at 10, and we'll finish the webinar at that time.
Thank you so much, Kimber, and thank you everyone for coming and sharing your thoughts. We will see you on Friday at 10 a.m. That same Zoom link will work the second day too.